Thank you for coming tonight, because it really has been miserably suppressive today, the heat, hasn't it? And I think a lot of people have already sent apologies and said they're not coming. And as you're probably aware, the people who've been before, we usually fill every seat and get all the extra chairs out at the back. So we're very grateful that you've turned up. You've come to listen to a very, very good speaker, so I'm glad you've made the effort. There's a few people who are very new and want to talk to other people, so we do the round tables for that very reason, that you can chat to each other. And it helps when you get to know other gentlemen going through the same. I'm Mary, by the way, if anybody doesn't know who I am. I'm the chair of Kidderminster Prostate, Northern Branch of the Prostate Cancer Support Group. And Gordon Kingston over there is our chairman of the South Worcestershire Pershore Branch. We have got several things coming up. Oh, first of all, I get into trouble from Mr. Mark at the back. If there's a fire, look for the man with the green thing where he's running. Follow that way, that way, that way, and that way. Hopefully we won't have a fire. They're having some terrible ones in France. We had a lovely meeting last week at Droitwich and at the golf club in Droitwich, and I met quite a few of you then. Thank you very much for turning up tonight. It was a very pleasant morning, chatting away and eating cake and having a drink of coffee. Again, it was a very warm day. We've got fitness classes which run on our website every Monday morning at 9:30 for an hour. And when you join, you just go onto our website and you can join the class. You just click on it and you can just join the class for an hour. Anybody can do it. It's done to your standards. The lady who runs it, Di Fox, is excellent, and she will help you through any problems you've got before and after treatment. Pershore Plum Fair is on Bank Holiday Monday the 29th of August, 11 till 3 o'clock in the afternoon. And the South Worcester branch will be having a stall and tombola there. And it's usually a lovely day. I'm hoping by then I might be able to drive. You never know. I'm hoping the fact that I've got an automatic car, it'll be all right. South Worcestershire are having their next meeting in Pershore on the 12th of October. Speakers to be announced, and our next meeting here in Kidderminster is on the 18th of October, and again, speakers to be announced, but it will be a very interesting night. The speakers I've booked actually may back out, so I'm not putting it in until we get to the next supporter, and then it will go in the magazine for you. Right, I want to introduce this wonderful gentleman who's travelled a long way to come and see us today. This is Steve Allen. Steve Allen was an anaesthetist in which hospital?
Royal Berkshire, Reading. Now, everybody used to say it was Reading General. Reading General was the railway station, so if you had your operation at Reading General, it wasn't quite up to normal standards.
He worked with the urology team, so he worked with surgeons who were doing prostatectomies, and eventually was diagnosed himself with prostate cancer. I'm sure Steve will introduce this into his talk for us today, and he'll be talking about current treatment pathway. Things are changing a lot in the care of prostate cancer. Barriers are being broken down, and we're going forward with new treatments every week. It's amazing what is going on. And Steve will lead you through this and talk to you about it. Any questions afterwards, I'll go around with my little lollipop and you can ask Steve a question and he will give you an answer. Thank you very much.
Mary, thank you. You are far too generous. Yes, I'm an anaesthetist. I'm an absolute, complete and utter idiot. Why do I say that? It's because, yes, I was diagnosed 14 years ago. I had studiously ignored my severe prostatic symptoms for around 2 years before I did anything about it. Now, as all of you are very involved, I know, in this area with awareness, that in itself is stupid enough. Members of the public should know better than to ignore their symptoms. All right, yep, I was a doctor. That's even worse. Yes, I was an anaesthetist. We passively shouldn't really know much about your prostate because we don't put prostates to sleep, it's your brain. But Mary was right. For 25 years, I worked as one of the senior anaesthetists in the urology unit at Reading. I was anaesthetising 3 times a week men who had prostate problems, and yet I ignored my own. The reason for that is that I was convinced that I had benign disease. My PSA had been consistently at the upper limit of normal for 7 consecutive years. In those days, we had not quite realised that that puts somebody like me in a slightly more at-risk category. If your PSA is in the upper 25% of normal, then it's something that's not diagnostic by any means, but it does raise just a little bit of alarm and something that you should be thinking about. Why did I bother to have anything done? Well, to be honest, at the age of 60, I was either going to retire or I was going to go part-time for medicine. The insurance figures in those days, and I think they're probably true now, was that if a doctor retires at 60, then he'll live longer than if he retires at 65. And I looked at how much pension I was going to lose, and to be honest, it was a no-brainer. I thought, I'm going to go part-time. Now, if I needed a rebore, which I knew I did, then probably the best thing to do was to have that on full pay rather than a pension. So 3 months before I was due to retire, I went and saw my mate Derek, that I'd worked with for 25 years. And I said, Derek, I think I need a rebore. He said, lie on that couch. He shoved his finger up my bum, and he knew then I'd got a small cancer. I was, in some ways, lucky. My cancer was, by today's standards, mild. I had a Gleason 6 cancer, very differently managed today. As many of you know, I ended up with radical treatment and all sorts of little problems which I've talked about. But the important thing is that we keep men and their partners aware of what's going on. And I know Kidderminster, Warwickshire, Worcester rather, you do a lot in the way of awareness. So when I was asked to talk about something tonight, I thought, what am I going to talk about? We were going to talk about pathways and all sorts of things. Now, many of you probably know that I'm involved with NICE as a patient representative, and a lot of that is looking at new drugs for very advanced cancers, and quite rightly so. What we don't look at it a lot is the other end. And I thought one of the thoughts that were going through my mind when I was thinking, what could we talk about tonight, was let's look at the front end. It's very easy to look at the far end. Let's look at the immediate end. And a lot of questions get asked sometimes. You know, we know that more men are now being diagnosed at an earlier age. That's important. It shows that awareness is working. It shows that men are thinking about their prostate health. Many men are still diagnosed at an early stage, but not enough. The figures from the National Prostate Cancer Audit are not as encouraging as perhaps it would be nice to be. Of newly diagnosed men, 40% will have their cancer already spread outside their prostate capsule. 40%. Now, that may be only very, very localized outside. But once you've started breaching this wonderful prostate capsule that God gave us to keep our cancers inside, Once you've breached that capsule, then your treatment options radically alter. Of that 40%, 17% of men at the time of their diagnosis already have distant metastatic spread. These are horrific figures. We are beginning to do something about that with awareness. Now, the argument's always, and I'm sure many of you have heard those arguments, particularly recent. Well, you won't have read the BMJ, but there was a terrible editorial about I don't know what the opposite of wisdom is, but the opposite of wisdom, all about PSA screening, all about testing for prostate cancer and how rubbish the PSA test is. And yes, if you want to diagnose aggressive prostate cancer with a blood test, you're not going to do that easily with a PSA. But PSA is all about prostate health. And that's the important thing, I think, to get over to all these people. That if they have a raised PSA, it's pretty sure something's going wrong with your prostate. The likelihood is it's not a cancer. But it's all about questioning your general prostate health. And of course, everybody was worried in the early days about overtreatment. And we certainly did overtreat people. I was almost certainly grossly overtreated by today's standards. Gleason 6, and I'd be offered something else. But I had radical treatment. So it's all important about doing that. And, well, how have things changed? It's 14 years since I was diagnosed. The pathways that we use, the treatments we use, have radically altered. So what you've got to do is to have a little catchy title for your talk. And this came about, seriously, because I was in the car and I was listening to Tony Blackburn's Sound of the 60s programme, brilliant show. Tony Blackburn is one of the most amazing men I've ever met. I used to talk on local radio occasionally, and he was a guest DJ 2 or 3 times, and he's a stunning bloke. Absolutely stunning. I know lots about his personal medical history, which I'm not allowed to share with you, but never mind. But they suddenly came up with this song, What's New Pussycat? And I thought, that's what I'm going to call my talk. Because we talk about pussycats and we talk about tigers. Now, if you're in the 60s, you'll remember the film. Well, you might do. Peter O'Toole, Peter Sellers. You might remember Tom Jones' dreadful song in 3/4 time. I won't sing it now because I know that Dan will turn the microphone off. But it is an excuse for those of you who want to see pretty pictures of kittens to see a pretty picture of a kitten. So what's new about pussycats? What's new at the front end of diagnosis? Well, multiparametric MRI has changed the absolute field, hasn't it? And you all know that. This is revision. It's nothing new to you. It allows you to accurately identify the size, the position of the prostate. Now, one of the big problems is interpreting. Now, you don't need, it's probably a bit bright on the screen, isn't it? But you don't need to be medically qualified to see here is the prostate, there is the urethra going through the prostate, there's this ruddy great lump there, and an even worse bit of lump there. That's a cancer. That's really barn door. Some of them aren't quite that easy, but the important thing about this is that you can see at the top, although it's very small, that cancer has already gone through the capsule. This chap, had he been diagnosed perhaps a few months earlier, may have had a different set of treatment options. Now, one of the problems, yes, something like now, it's on the NICE guidance pathway. Every man who has an abnormal PSA, its next test should be a multiparametric MRI, and around about 86% of the people in this country are getting that now. One of the difficulties is getting enough people to interpret the scans properly. You've got to train people. And yes, we'd like to do more. The more people you diagnose, the more scans you'll do, the more call there will be on interpretation. And there are already computer programs looking, using artificial intelligence to look at scans like this. And one of the things you get from that is things called a PIRAD score, Prostate Imaging Reporting and Data System. Has anybody heard of the PIRAD score? It's just a way, like Gleason, of identifying and trying to stage your cancer. So you get a Gleason score before you've even got your biopsy from the results of your multiparametric MRI. They can have a pretty good idea of how clinically likely you have an aggressive cancer. Is it any good? And the in term is called negative predictive value. Around about 95% of people will get an accurate diagnosis. There will be some, obviously, whose cancers are so small and possibly insignificant at that time, but will become positive later. So it's not absolute, nobody would tell you that, but it's pretty good. And there is now something, has anybody heard of this thing called the prostagram? Gordon has, he's smiling. This is a simplified multiparametric MRI. Only takes, they say, 10 to 15 minutes. And the people that are trying to introduce this as a screening tool are saying it is as good as PSA and possibly better at finding aggressive prostate cancers. One of the things that's being put forward is whether or not this could take the place of a rectal examination in somebody that has an increased PSA. And as you all know, one of the big problems in life, one of the groupings that are more difficult to get to come to be tested are the black ethnic minorities. These people very often won't come to be screened, to be tested, because they do not want somebody shoving a finger up their backside. Now, if you can take that away and say you don't need this anymore, can we get more people to come and be tested? And I think it's a really, really important thing that we'll be thinking about in the future. Interesting, there was I'm very good at going off-piste. There was a report from somewhere in the Midlands, I can't remember where it was, where they were going round doing PSA testing and doing some rectal examinations, and they found that black men were happier to have a female doctor do their rectal examination than a male doctor. So perhaps that's something, again, we need just to put in the mix into, how we treat patients, what we do. Biopsies have changed, as you know. Most of you, like me, will have had the standard transrectal biopsy. Now, transperineal biopsies are becoming the more standard. 2 puncture wounds, some bit of kit. There's the ultrasound probe that goes up the rectum, and there are just some guides where the needles go through under local anaesthetic. So much better than having a transrectal. Less infection, less problems. Template biopsies, I'm sure you all know about. Again, made easier by multiparametric MRI, because you know where to try and guide all of your needles. This is the one thing that's becoming not yet introduced. It's undergoing a review by NICE, but it's looking at taking the images of both your MRI and then the live ultrasound pictures and putting them together on one screen. So you do the MRI, and then the surgeon, whoever, can map out your prostate. And then when you put the ultrasound image on top of that, you can get more accurately where your needle's going. And you get some very pretty coloured pictures. Pretty coloured pictures are always impressive. So there's the outline of the prostate on the MRI. That's the ultrasound image, and there are the areas that need to be targeted. This is just about to be appraised by NICE, It's going to take at least a year or two before they think about putting that into guidelines if they do. So if we can diagnose a little bit better, are there better treatments that we can do? Is everybody, or how many people now do not need to have the radical treatment that I had? So one of the things that didn't exist when I was diagnosed 14 years ago were these two words, active surveillance. Yes, we talked about watch and wait, and nobody really understood what that was. Active surveillance is very different. And many people on helplines, and I'm on the Tackle helpline, the younger population are asking about things like this. Is it any good? Who can have it? What are the benefits? What is it involved? Yes, it's fine, but what's the recurrence rate? Do I need further treatment? It is a good option for low-risk cancers. So we're talking probably Gleason 6, possibly 3+4 if it's a 7. And it's a really good option these days, particularly if you've got a one-sided tumour and it is very localised within the prostate. And you can see that from your multi-parametric MRI scans these days. And of course, it totally avoids the need for any treatment. So you don't get any side effects. It's basically saying, yes, we know you've got a cancer, but we believe from your PIRAD score, from where it is, the size, that this may well be a very low aggressive tumour, and it may well be you never need treatment. Now that's difficult to say. That's difficult for people to understand. Yes, I'm sorry, Mr. Smith, you've got a cancer. Next breath, no, we're not going to do anything about it. For God's sake, you just told me I've got this cancer. Cancers need to be cut out. They need to be treated. You're telling me you're not going to do anything. Well, as we know now, many prostate cancers are very slow growing. Many may never need treatment. What is it? Estimated 1 in 3 men over the age of 80 have a slow, small prostate cancer that they don't even need to know about. It will be something, as they say, you will die with rather than because of. And of course, if you're regularly monitoring that patient properly, then as soon as things start going slightly awry, then you can do something about it. And it's picked up early enough before it's spread. And I don't ever believe people are cured of cancer, or rarely. I think I'm still in long-term remission. And I'm 14 years down the line. It's as near to cure as you'll get. So the wonderful phrase that doctors use is treatment with curative intent, which covers a few bases, really. But that's possible if you follow this quite carefully. You need to be regularly monitored. You may well need lots of biopsies, or more biopsies than you'd normally do. And yes, there are some cancers which suddenly seem to change. Yes, one year it may be a pussycat, and the next year it may be a tiger. So it's something which needs to be carefully monitored. And yes, this year, I'm 70, God, what am I, 74 now. Who knows what my general health might be like next year? I could have had a stroke, I could have had a heart attack, all sorts of things could have happened. And that may coincide with my cancer going wrong, and therefore I may not be suitable for all the right treatments. So it's a really good option, but it is one which needs careful consideration by the patient. Can you cope with knowing there is a small but slow-going cancer inside you? That it may never get bigger, it might do. It's a hugely difficult emotional thing for some people. It's not difficult to do. You just get regular PSAs. The other lovely term, PSA kinetics. Basically, that's the posh way of saying we're going to do your PSA regularly and see how fast it changes. So you can call that PSA kinetics. But it's all about doing that. You may need rectal examinations yearly, multiparametrics, and that will go on for as long as you need to. But what's the outcome? What's the recurrence rate? What's the failure rate of this treatment, if you like? How many people go on to need treatment? That's what I want to know as a patient. If you're going to offer me something which isn't active treatment, I want to know how many people actually go on to need treatment later on. That's important. And around about 98% of men will still be alive at 10 years on active surveillance. That's, I think, a very bad figure, because it doesn't tell you what their quality of life is like at 10 years. Yes, some men may be alive, but they may have then needed treatment and they may not be feeling very well now. So I don't think, personally, and this is my personal opinion, I don't think that's a really good figure to be bandying about. What I want to know is this: 40% of patients will have had treatment 5 years down the line. And that will be for a variety of reasons. Yes, some people will be getting the progression of their cancer, so it now needs treatment. But within that 40%, there are undoubtedly people who psychologically say, look, I can't go on like this anymore. I can't live with a time bomb inside me. I'm well, let's get on and let's do something about it. What about local therapies? And they didn't exist 14 years ago when I was diagnosed, and they are becoming more widely talked about. Who can have it? Is it a good option? What are the advantages and disadvantages? What can we do? And is local therapy any better than having radical treatment? Well, the sort of people that would be considered for this, or the sort of people that on helplines ask about it, are very often younger people who are worried about having radical treatment and having side effects because of radical treatment. So newly diagnosed people with low risk to medium risk cancers, preferably localized to the prostate. If it's spread outside, then it's much more difficult to do localized therapy. But the same techniques can be used if you get small recurrences after radical treatment, such as radiotherapy. So it is a combination of things. Much less side effects, because it's local therapy. You damage nerves, you damage continence systems much less. Often performed as a day surgery, if you're lucky. Catheter needs to be in for a shorter period of time, in the main only 3 days, and it can be repeated because you're only doing this therapy locally. And there is a sort of comparison here in many ways. I don't know whether anybody's ever, unfortunately, had a relative who's had, it was my relative who had colon cancer, but he ended up with small deposits in his liver. And sensitive scans kept picking up small, very localized, sorry, I got an itchy nose, localized deposits in his liver. And he was able to have then just a needle shoved through the skin into his liver, which burnt away his secondaries. And he ended up with, and I can't remember exactly, it was either 5 or 6 goes before he died of something else, keeping his local recurrences under control. So local therapy for the prostate is something, I think, that we will be thinking of much more in the future. The recurrence rate, 20%, will need another focal therapy at 5 years. 7% will need radical therapy. And much of this will obviously depend on good choice of patient. Having somebody who assesses your cancer and you and where it is. Now, it's very technology heavy. You need very different skills as a surgeon or as a medical practitioner. It is not yet available. None of the local therapies are actually widely available on the NHS unless you're in a very big cancer centre where they're doing research. And I've got to say, one of the problems are surgeons. Let's speak closer into the hidden microphone. Surgeons are very often slow to change. I've always done. I saw it a long while back when we first started doing gallbladder operations through a telescope. The number of older surgeons that were absolutely hopeless at looking down telescopes, but B said, I can do this in 20 minutes and I can make an incision only that big. It took a lot of inertia now. If you have your gallbladder out, you'll have it done as a day case through a telescope these days. That's how surgery has moved on. I was asked to talk as a patient to the British Association of Urological Surgeons about my experience of radical prostatectomy. And I finished off by saying, there are robotic procedures now, which I didn't have. I had an open procedure. But I said, my wish is to come back and talk to you in 10 years' time, and none of you will be doing radical prostatectomies. I hope you're all going to be doing local therapy, because we will be diagnosing men so early that they don't need radical therapy. We're always going to need surgeons, chaps, but you're going to be doing different things. I'm not quite sure how well that went down, but I haven't been invited back yet. So what can you do? How can you destroy things locally? You can heat it up, you can freeze it, you can electrocute it, and you can shove toxic chemicals into it. It's quite a choice. Heat is basically this thing called high-intensity focused ultrasound. Everybody knows about ultrasound. It's a diagnostic investigation, but if you wind the wick up and you focus it enough, it vibrates those cells so fast and so hard that they get very hot. And that's what destroys the cancer. And that can be done very easily and very localized. And HIFU is now it's not uncommon in private practice. And there are a couple of centres, I'm sure they're doing it, a few centres around here. You can freeze it. If you freeze a cell and then it thaws, it will die because you destroy the cell itself. So you need to target, and you shove lots of very cold needles into that area, and basically you freeze them to death. Both of these produce local damage. Yes, you'll get local swelling of the prostate, but hopefully that goes down quite quickly, so the catheter that you need afterwards doesn't need to be in for too long. This is wonderful. Irreversible electroporation. Basically, that's putting a couple of electrodes in your prostate, shining electric currents through it of whatever frequency and whatever, but it basically punches holes in the cell membrane, and the cells then die. It just destroys the cell membrane. This is currently going through appraisal by NICE. Whether or not it will get approved or not, I don't know. But it just demonstrates the various ways in which we can now physically and locally damage your prostate cancers. Local toxic chemotherapy, if you like, it's only just about on the horizon. But it's an interesting concept. The first one was this thing called vascular targeted photodynamic therapy. Lots of big words tonight. I mean, you have to have a drink when if you're going to have a big word like that. Cheers. Basically, what this is doing is it takes a chemical and you inject it into the patient. That chemical is actually inert. Don't do anything. But if you shine a very specific wavelength of laser light on that molecule, it gets changed. and it gets changed into something which is highly toxic. So for this particular thing, you inject it into the patient, and then you take them to the theatre, and then you put laser fibres into the prostate, where you know from your multiparametric MRI the localized cancer is. That light shines in the prostate, converts the local chemical into a toxic chemotherapeutic drug. It has not yet been approved by either the FDA or NICE. There was a drug called padeliporfin, which was being, it came out about 5 years ago, but it really hasn't caught on, mainly because, certainly in England, the patients they were using were very low-grade patients with single-sided disease, and to be honest, they'd probably do as well if you just sat and fanned them with your hat and put them on active surveillance programs. But it may well come. Who knows what's going to happen in 10 years? The other thing, and this is very much in the future, but is being talked about, are local infusions into the prostate of chemotherapeutic drugs. Now we know, clever radiologists can now put dye into you, and they can find any old blood vessel and can tell you where it's going. And this is a picture of, it's actually a benign prostate, but you can see there's the major artery supplying that side of the prostate. Now the argument is, can you just do that for a cancer, and you thread a catheter, very fine catheter like people have had. Has anybody had a cardiac stent? Come on, somebody must have done. Yeah, basically that's what they're doing. They're localizing the area of your coronary arteries. So using the same sort of technique, is there a possibility in the future that we can use highly toxic drugs, but they don't have systemic effects? I think it's fascinating. And I bet in 10 years' time, it may well be a lot more on the agenda. But is it better than radical treatment? There is something I remember well. When I was diagnosed, yes, you've got a cancer, the knee-jerk reaction is, big C, cancer, cut it out, get rid of it, I want it in the bin. Is local treatment any better than doing something as advanced than that? And yes, it's all about a balance of side effects and recurrence, and can you do something about it? Very much availability at the moment. This, for most people, is not available on the NHS unless it's part of a research program. It is available in the private sector. And that is one of the difficulties in life, I'm afraid, of having a national health service and a private system. There are arguments about radical surgery. Robotic radical surgery now is a very different animal to the open techniques that I had 14 years ago. The recurrence rate is, if it's localized, is 0. The incidence of side effects is very much lower with decent modern robotic techniques. Yes, it depends slightly on the surgeon, but I recently, there's a chap locally I was supporting who went and had a fairly advanced robotic procedure done in London. His catheter was out in 5 days. He was continent 2 days after his catheter had come out and has never ever worn a pad since. And he was 54-ish. And by 1 month post-operatively, he was as sexually active as he was pre-operatively. So it's a difficult decision sometimes to make. You have to weigh up everything. But have I bored everybody rigid? Do I need, is that all right? About another 10, 15 minutes, is that okay? Yeah, we talked about the pussycats. What about the tigers? And there is a lot happening with advanced cancer. New scans. Well, PET scans, PSMA scans, are they the same? Is one better than another? Most people will have had an MRI or a CT. Now, MRI and CT are brilliant. They are very good scans. They can be very sensitive. They can be very accurate. The big problem is that what I would define as a passive scan. They're telling you about tissue density, about shape that was present whenever your scan was done. It's, like I say, it can tell you size, position, character to a certain extent, but it doesn't tell you about how that tumour, how that organ is actually working. And, you know, CT uses X-rays, MRI uses magnetic fields, and there are certain scans which are better done as a CT, better done as an MRI. But what's PET? Positron emission tomography. This and a PSMA scan is what I would call an active scan. Its whole idea is to show cell activity. Now, with a PET scan, you introduce a radioactive molecule which is taken into the metabolism of that cell. So as that cell works, it's using this radioactive compound, and you can detect that with some sort of special scanner. The original ones use basically radioactive glucose. As you know, glucose is the powerhouse behind every cell. It's what provides your energy. Radio label that, and they used fluorine, and the more active a cell is, the more radiation it will produce and that you can detect. And you can get some pretty coloured pictures. And what you see here, and most scans of, it's called nuclear scans, I suppose is another way of looking at it, will show areas of activity. And there's your liver, very active. There's a spleen, there's a kidney, there's another kidney. You can see uptake in the bone marrow, in the spine there, which is obviously their active cells. What's that? That is a lump, a highly active lump in the lung, which should not be there. So the art of interpreting many of these scans is knowing where there should be activity and then looking for areas where there shouldn't be. And you can try and make those slightly more specific for the cancers you're looking at. Fluorine deoxyglucose was good. For prostate cancer, choline was the first thing that was used, or a fluorine-based one. Choline's used in cell walls. It's much more sensitive for prostate cancer cells. And you can see there's the pelvis, and that's a lymph node somewhere in the depths of that chap's pelvis. The trouble with choline, yes, it's radioactive, but it's not easy to make. You have to use a big cyclotron thing, and there were manufacturing problems. I think most of the UK's stuff is now made in Belgium. Okay. It can be very sensitive. There's a few areas which, some active bone marrow there and there, but there's something there which shouldn't be there. That's probably another lymph node. But what's a PSMA scan? Has everybody heard of a PSMA scan? Most people? Or not? No, okay. This is very different technology, and it's all about how cells communicate, if you like, with one another. Now, there's a cell, very simple diagram. That's the outside cell wall, there's the inside of the cell, and it's got a nucleus. Cells are covered in little receptor sites, absolutely thousands of them. And they all have a special function. So each receptor may well be specific for a certain task. Each receptor has a very specific shape, if you like, to identify it and its function. And you can send messages chemically to that cell with the right sort of molecule. And the cell messenger, if you want to be posh, is called a ligand, but that can be either an atom or a molecule. And very often they're hormones. So something like testosterone could be this ligand. There's the testosterone receptor on your prostate cancer cell. Testosterone sits on that and tells that cancer cell to grow. But each cell's got vast amounts of different chemicals surrounding it. So it's only that very specific chemical, that very specific hormone, that very specific molecule, which will actually sit on that receptor. And you may have heard of this sort of concept called lock and key, where each receptor has a very specific molecule which occupies the receptor. Now, once it's occupied, it then triggers actions on that cell. It could be telling the cell to grow. It could be telling the cell to make another hormone, like telling your testicles to make testosterone, all sorts of different things. But there is this function, something sits on that receptor, and it produces a reaction. So, what do we call PSMA? Prostate-specific membrane antigen. And it's basically just another receptor. Prostate cells have got very specific receptors, and they're very large, quite lots, and particularly on prostate cancer cells. Cancer cells have more of these receptors than your normal ones, which is quite useful. So these things can be called prostate-specific membrane antigens. They're the receptors. And a molecule has been designed which will sit very specifically on that single receptor. Doesn't do anything anywhere else, so it specifically occupies that receptor. But the molecule, all right, sits there and, hey, look, I'm here, doesn't do anything. Is that a waste of space? Well, in some respects, yes, if that's all you're going to do. But what the clever people have done is they've glued something to that molecule, and what you glue to it is a radioactive substance. That radioactive substance is called gallium-68. So now we've got something sitting on that receptor which is now radioactive. And we can now pick that up with a special scanner called a PSMA PET scan. It gives off what are called positrons, and those you can measure. And what that allows you to do is to scan the patient and to find areas of high concentration of this specific subject, specific chemical. And that has to be, supposedly, prostate cancer cells. So it's a way of very accurately looking for prostate cancer cells. The trouble is, I don't know if anybody ever seen their bone scans, or they look a bit like black and white x-rays, but they're very fuzzy. They're not very sharp. So what you can do is combine a PSMA scan with a conventional CT scan to get better images. But, and this is the big but, when everybody started talking about PSMA, prostate-specific membrane antigen, brilliant, wonderful. It's not prostate-specific, sadly. And why they ever called it that, I'm not too sure. Because other areas of your body pick up gallium-68. They've got receptors that would liver, kidney, spleen. So prostate-selective may be a better term. But prostate cancer cells have 10 to 1,000 times greater number of receptors than other cells. So it's easy to turn the volume down on the scan, if you like, to pick up those areas which have got the greatest activity. And interestingly, men that have been on hormone therapy make even more of these receptors on their prostate cancer cells. And these scans are very often used for men who've been on hormone therapy, who now have a rising PSA, but conventional scans don't pick up the secondaries. So you've now got the opportunity to find secondaries which are much smaller and at a much earlier stage. And again, how do you interpret it? Well, it's all about, again, knowing where there is normal activity and where there shouldn't be any. That's somebody who's started their PSMA scan. You can see it's a pretty fuzzy old image, but it's as good as you're going to get. There's the kidneys, they've got a lot in it, liver, spleen, and fascinatingly, it's picked up by your salivary glands and by your lacrimal glands, your tear glands. God alone knows why your tear glands and your salivary glands pick up this stuff as well. I have not got a clue. What has happened, though, fascinating, is that in some people they've identified a new salivary gland which they never knew existed. It's not in everybody, but they found an area of uptake which is almost certainly a different salivary gland. But that's the sort of thing you might see in somebody. This is Martin. This is Martin on the left. And he'd had treatment, and then his PSA started rising. Conventional scans couldn't find anything at all. He went off and had a PSMA scan, and that's him. And that is a single lymph node in his pelvis. That's only 5 millimeters across. That would not have been found by a conventional scan. That allowed him not to need huge amounts of systemic therapy. It allowed him to have earlier treatment, localized, in fact, radiotherapy is what he had. But this is how sensitive these scans are becoming. And there are many people now who believe in 5-10 years' time, we won't be doing PET scans at all, they'll all be PSMA scans. And if you fuse the CT scan with the PSMA scan, you get much better definition. There you are, you can see that's nicely outlined his pelvis. And there's a tiny, tiny little bit of high activity there just below his kidneys. That's his aorta. And that's, again, a small lymph node about 4 millimeters across. That was Martin 5 years after he'd had his first treatment, and he needed then more localized treatment. So this is fascinating stuff, or it is to me. You're probably all bored out of your brain. Can you use this for treatment? Yes, you can. Using these techniques. If you've now identified your prostate cancer cell with radioactive gallium, gallium's very low radioactivity, short-acting, half-life of about, I think, 8 hours, something like that. Take that off, unglue it, and then put something else on. And what you put on is lutetium-177. You glue bits of lutetium to that carrier molecule. This is highly, highly radioactive. But what's important is it's only effective for a very short distance in the tissues. Anything between about 0.2 of a millimeter and at the very maximum 1.5 millimeters. So you've now got a radioactive chemical on the prostate cancer cell which is going to give very localized treatment. And this is what is currently being appraised by NICE. Theranostics is a wonderful word. It combines therapeutics and diagnostics. But it's using these techniques that we would normally have used for diagnosis now for treatment. And it's as old as the hills. You can call it molecular radiotherapy. I think that's very modern. It's not new. Has anybody had a relative, a friend who had a thyroid problem treated with radioactive iodine? That's molecular radiotherapy, where the tracer they used to identify the problem in the prostate was a low dosage of iodine, radioactive iodine, and you just used a higher one. and iodine is taken up by the prostate in its metabolism. The same happens for bone secondaries with radium-223. Radium is taken up instead of calcium into highly active bone cells. So if you have bone secondaries which don't respond to other treatments, you can use radium-223 as if you like, a calcium substitute. But sadly, there are many men who not only have bone secondaries, but they also have soft tissue secondaries. Radium-223 won't get into your soft tissues, but lutetium will. And this is something which, to be honest, I think is potentially going to revolutionise treatment. There's the chap. These are fairly old old images. That was in 2016. There's a bloke, PSA 356. He would have had treatment already. You can see he's got multiple secondaries. You can see brilliantly, there's his liver, spleen, kidney, all the bits we saw before, but he's got all of these multiple bony and soft tissue secondaries, which wouldn't have, they've probably been treated with chemotherapy and various other things. So he would have been very end stage, poor chap. Lutetium did that to him. It was taken up by all of these local secondaries, and that's what, 7 months later after. Very often it takes 3 or 4 sessions of treatment, and there he is later on. And there he is, still with his salivary glands picking it all up. Absolutely brilliant. So this is, I think, and I'm not being paid by the company, but it is, I think, an exciting way forward when we're talking about treatment. Gene therapy is another way of doing it. We've got, I've gone on for too long, but basically gene therapy now is looking not at changing the genes in your cells, but looking at the way you repair damaged genes. And there is a drug which, called olaparib, which targets the repair mechanisms in your prostate cancer cells. So when a cell divides, it very often damages its DNA, and it knows it's done that, so it repairs it. If you can stop the cell from repairing its DNA, it will die, and this is what's happening, particularly, as we know, in BRCA1 and 2 deficiencies. But it's the last slide. You'd be delighted to know, you must be bored rigid. But where do we go from here? There's just so much that could happen. Early diagnosis, certainly. Better screening tools for prostate cancer, undoubtedly. I would say that in my lifetime, we're not going to have a screening tool that's any easier to administer than PSA. It would take a very long while before we get that. More local therapy, yep. Less radical. Perhaps more earlier use of drugs and treatments that we use at the back end. If we use them all at the very front end, how many of those people would go on to get advanced cancers? And I'll leave you with that thought. Wouldn't it be wonderful if we could get rid of hormone therapy? It is the standard sort of thing that all patients are offered with advanced prostate cancer before they get anything else at all. It has got to be one of the most successful treatments at controlling prostate cancer, but one of the things which has got the most life-changing consequences. If we perhaps could find something that just blocks your testosterone on your cancer cells alone and does that very well, we wouldn't need to reduce the rest of the testosterone in your body. And very often, I'm sure as you know, men have always said, I don't feel like a man anymore. I'm sorry, I've gone on too long, Mary. I always do, but you're very foolish to ask me to come back.
Thank you. Can you... Am I doing all right, Daniel? Thank you. Who tells me what to do. Thank you very much, Steve. This is all very interesting. Sometimes you can't imagine that things can change so much, but I think there's certain things that we've got to make clear. A lot of these things aren't proven yet, are they?
They're not, well, they are proven, but they're not available.
They're not available. I did bring up HIFU, actually, at the committee meeting the other day. It's been around for 20 years.
Yep.
But it's never been accepted by the NHS. No.
Not yet.
And is there any figures showing the survival rates with HIFU?
Yeah, I mean, like I say, that around about 40% of people may need treatment further down the line. But the difficulty is that much of HIFU is still done in the private sector, so you don't get the feedback.
No, that's the concern I have.
And certainly I don't want people to go away thinking this is going to revolutionise the NHS. But one of the things which we as patients should be doing is making others aware that there are these things. We should be changing. You think of breast cancer and how peer group pressure changed the way breast cancer was managed. Yeah. You know, that women stopped accepting the fact they were just going to have their breast removed. And we need to be doing that with prostate cancer.
Right. Questions? Put your hands up, because you're all in the dark tonight. I can't see. Hold on. This gentleman first. Use the microphone.
Thank you. I've had two unusual PSA results. I'm tested every 3 months.
Right.
And the first one came back as 0.01.
Right.
And then 0.03, whereas before they were never able to measure that low.
What have you had done already?
Radiation therapy.
You've had radiation treatment, and it's, to be honest, the difference between 0.01 and 0.03 is almost bugger all. I wouldn't worry.
Is it the fact that they're more able to accurately measure these?
It depends on how the laboratory wants to report it. Some people never report. They will say your figure is below 0.05 or whatever.
Yes.
So
it's usually
at that sort of level, you're almost in the realms of background noise.
Right.
My PSA started immediately afterwards, my surgery, at 0.007 licence to kill. And it's now gone up to 0.04 over 14 years.
Yeah.
It's so small, you shouldn't worry. I know I'm not meant to give medical advice, and I mustn't do that, Mary, but that sort of change is not a problem. If your next one came back at 1,
oh yeah,
then because of what's happened in the past, and that's why I think it's so important when you guys get your PSA levels reported to you, do not accept it's fine. You want to know the figure. True. If somebody who looks at my figure at 0.04 and doesn't know I've had a prostatectomy, they're going to say that's fine. If I have it done next year and it comes back at 2, 74, 75, they're going to say that's normal for you, mate. If they don't know I've had a prostatectomy, I would be worried if my PSA next year was 2.
Yes. Yeah.
I hope it won't be.
Thank you very much. Sure.
Yeah, just a quick one. We hear that the NHS is under terrific financial strain.
Yep.
These new treatments, how cost effective are they?
That's the only reason that NICE will accept them is if they fall within certain categories, and it's all talked about quality added life years, QALYs. They are very, very strict about what they will allow and what they won't. Don't forget, you will never know what the NHS is paying for a drug. They will not get, whether the process of getting, new Wonder on through NICE, before the drug company can even get it appraised by NICE, they have to agree a discounted price with NHS England. And unless that's already been agreed, NICE won't look at it. Yeah. And I, as a patient representative on NICE, I constantly say, it is not my job to worry about cost. My job as a patient representative is to ensure that all men get appropriate treatment. It's somebody else's problem to pay for it. And any drug, any treatment which is actually appraised and approved by NICE, legally, your health authority have to bring it into practice within 3 months.
Okay, thank you.
I'm doing this for Mary, so she doesn't have to rush about. Let me bring it to you.
Thanks very much for the talk. It's very interesting indeed. I wish I'd heard this about 2 years ago when I was first diagnosed with cancer. I had a further MRI in November, phoned up the consultant and said, I haven't had the results. He said, you need to have a biopsy. Biopsy, it had got to a Gleason score of 8.
Right.
And that happened about a month or so back. If you're in Worcester, it's a postcode lottery in that what they offer you as far as surgery is concerned is the old-fashioned method of surgery.
When you say old-fashioned,
Well,
what are you
not
talking?
old-fashioned, well, they cut you open and...
They're not offering robotic surgery.
Can I just interrupt and explain that, in fact, although most of the work that's done for removal of prostate in Worcester truly is open surgery, many, many men are sent to Wolverhampton, Cheltenham, and so on.
I was going to go on and say something else, actually, because I've got a very good friend that's an ex-professor of urology, but he didn't do Dalton kidneys. So I went up to the Christie Hospital and
Right.
been there. So one's got the choice now
Absolutely.
between having an operation or having radiotherapy done.
Yes.
The radiotherapist, the oncologist, was lovely. One of the things that my friend criticised was they didn't have a meeting together between the oncologist and the urologist. He felt that they should be in the same room and discuss
it should have
things.
been an MD2.
The difficulty that one has, and I've got to make a decision, I think, in the next couple of days, is whether I have an operation or whether I had radiotherapy. The difficulty with an operation at this moment in time, and I would go down the robotic route definitely, is the waiting times, because they're, I think, currently, Peter Cook, who's very good in Wolverhampton, is saying it's about 6 months, which is, from what you were saying, is quite a long time to wait. I've started hormone replacement.
No hormone replacement.
Yeah, as 2 weeks ago.
Right.
So I'm at a crossroads. I've got to make a decision. And it's a decision which is not black and white. It's a decision which is
Yes.
degrees of grey. So I'm just throwing you a...
Yeah, I obviously can't advise you. The fact that you're already on some ADT, some hormone therapy, should hopefully reduce the metabolism of that cancer. It will reduce the size of it potentially, which would then make surgery easier.
Yeah.
It's not something really I can advise you on in public.
If I'm the same age as you, actually. I don't know whether you were born in 1948, which was...
Absolutely, 5th of March.
Right. So we're both born in the year of Prince Charles. So it was a vintage year. But obviously I'm getting to the age whereby they're saying that an operation has greater risk.
That depends not on your chronological age ever, in my book. It is on your physiological age.
Yeah.
And there are many men at the age of 74 who are incredibly fit, and there are some men at the age of 54 who are not.
Sorry to throw the last one at you. If you had money to throw at it, would you have it throw money at it and get it done tomorrow?
I
Our
would
progress.
then seriously consider the options that were available that I could pay for, is all I can say.
Yeah. Okay. Thank you very much indeed. Sorry to put you on the
No,
on
no,
the
you
spot.
don't not put me on the spot at all. I think what's important to say is that under the current NHS, every person has a right to choose the hospital that treats them. And sometimes that's difficult to do. You think you're going to upset the local boys. I have certainly advised people sometimes to go out of area. But that's a personal thing.
Thanks for a lovely question. Any more questions over there? Where are we up to?
They're all desperate to go home. They can't stand me anymore. It's your own fault. You invited me back.
And we're delighted that you did come back.
Well, you're only ever
any
asked.
more
There are only
questions?
two reasons why people ask you to do something again. One is that you were best thing since sliced bread and they want you back. Or, yeah, you weren't bad and we know what we're buying next time.
I think some of the things we've heard tonight are, as ever, these areas that our questioner just referred to. They're areas of grey, aren't they? You know, the great thing these days, quite honestly, Steve, is that we have options,
Yeah.
both in the sort of surgery that can be carried out and the pre-treatment and the following treatment as well. And thank goodness some of us are around here to prove the point.
And certainly, if you're ever given the opportunity to go on a trial or be part of a research project, embrace it with both arms, because you will get the best possible management and monitoring. Even if you're on the placebo side, they will pick up something before they would normally have done so. So I think trials are brilliant, and living near a major cancer centre is a great postcode lottery.
Thank you very much, Steve. That's been a wonderful, interesting look at the future. A lot of it is the future, you know, so we work with what we've got and we all make decisions we have to make with our own surgery, radiotherapy, or whichever way we decide to go. It's nice to get together and talk to other men, and I think a couple of buddies have got to be sorted when I get back after my operation, which I will do. But there is food, a buffet in the other room, if you'd like to go through to that, and there's a bar, get yourself another drink. Please
And
enjoy.
I think we all wish Mary well for her operation tomorrow.
Thank you.
Yeah.
Can we just say one other thing, without sparing his blushes? I'm not sure that Mary referred to the fact that Steve, of course, is now this elevated status of chairman of Tackle, okay? I'm not so sure that was
Acting
mentioned
chairman.
before.
I'm
And I think
not-
we
I'm going
we
to be
really,
voting.
well, interim, but chairman. But I think we ought to thank him for both the terrific commitment that he makes to Tackle, the change in this body that is the federation of all the support groups, 90 plus across the country, is tremendous. They were in a bit of a mess, you know, only a short while ago. And fortunately, a band of new trustees with a super-duper interim chair have now taken over, and what with his push, the trustees, and we've got a splendid trustee in our own region, Aidan Adkins, that some of you saw at Droitwich the other day, and also a splendid development manager in Sarah Gray, are really providing groups like us with a lot more help and support to people like
But it's
Mary,
what
who
we
does
get
so
back
well.
from you and your sort of groups, which is just as important. That there are many people out there that you know, we have no idea sometimes whether people actually open their emails, or we do now because we've got the technology.
Yeah.
But no, thank you.
Anyway, thank you very much. Safe journey home. Come and have some food. Thank you again.